Good morning, all. Today we'll be discussing about motility disorders of esophagus. The objectives of this seminar is to study in brief the esophageal anatomy and physiology, the diagnostic modalities for esophageal motility disorders, the classification of motility disorders, about achalasia cardia, the pathogenesis and clinical presentation, the Chicago classification of motility disorders and the management of the same, the conservative approach and the surgical management. The esophagus normally is 10 centimeter in newborns to 35 to 40 centimeters in adults. Structurally is made up of four primary layers: innermost mucosa, submucosa, muscularis propria, and adventitia. The muscle layer is innermost is circular fibers and outer longitudinal fibers. The upper third consists of striated muscle and lower two-thirds of smooth muscle. There are two muscular sphincters, the upper esophageal, which fuses with the cricopharyngeal muscle, and the lower esophageal sphincter, which are circular fibers which adopt at the gastroesophageal junction in a U shape on both sides. The function of the esophagus essentially is the alimentary bolus to propulse the alimentary bolus from the pharynx to the stomach and the clearance of fluid refluxing from the stomach. It essentially works on the abdominothoracic pressure gradient. The primary waves are the rhythmic contractions, which are initiated by the interstitial cells of Carl, which is present on the muscle fibers and play a pacemaker role. The excitatory activity in the vagal nucleus and the nucleus ambiguous results in the release of acetylcholine, and which further results in the secretion of inhibitory neurotransmitters, that is nitric oxide and VIP, which further results in the deglutative inhibition. Further down the esophagus, there is increased inhibitory activity, which is known as the latency gradient. The secondary waves are generated when there is reflux, and it initiates as a peristaltic contraction, which is independent of deglutition, and it can arise at different levels. It leads to the addition of the alkaline saliva. The tertiary waves are limited simultaneous non-propulsive motor waves, which are essentially for the closure of the lumen of the esophagus. The evaluation for the esophageal motility disorders are by barium swallow, which results in the diagnosis of anatomic anomalies of the organ, abnormal contractility and relaxation of the sphincters. However, the irradiation limits its use in children. Scintigraphy is based on liquid or solid radionucleotide tagged meals, which helps in the assessment of esophageal transit and assesses the esophageal and gastric emptying. Again, its use is limited in children. Endoscopy is an evaluation tool which helps in the direct inspection of the lumen and the mucosa, and also enables us to take a biopsy of the mucosa when indicated. Puckered gastroesophageal junction and pooling of saliva in the proximal esophagus are two findings which are commonly seen in motility disorders of esophagus. Extended pH metry helps to quantify the extent of acid exposure and helps in a correlation between the motor function and the clearance capacity of the organ. This image shows a strip chart display of a 24-hour pH metry, which shows an increased acid exposure. Manometry is the main tool for the assessment of motor function, and it is based on the principle of Pascal. The pressure at any point of the esophageal lumen can be recorded, and thus it helps in assessing the sphincteric function. A pull-through manometry recording is done of LES with abdominal pressures in this particular graph. The plateau shows the high pressure zone of LES, and when it enters the thoracic esophagus, intraluminal inspiratory deflections become negative. This can be combined with pH metry, and a 24-hour ambulatory manometry can be done to increase the results which we can achieve. The another mode of evaluation is multi-channel intraluminal impedance, using which a long duration recording is possible. The reflux detection is coupled with the pH recording, and by which the acid nature can be assessed. This allows for assessment of deglutition and the esophageal motor activity. However, the use of this is limited in children. The high resolution manometry is the gold standard for the diagnosis of esophageal motility disorder. This particular graph is a study of a graph of normal high resolution manometry study. In this, the x-axis correlates with the time and the y-axis correlates with the different parts of the esophagus. The pressures that are to be recorded are color-coded, ranging from the low pressure of blue to high pressures of the red and violet. There are 10 swallows that are recorded in the HRM, and when the swallow when the swallow is done, after which we can see in the lower part there is a lower esophageal sphincter relaxation which we can see. There are 4 metrics which are important to interpret the HRM, which are the integrated relaxation pressure IRP, which describes the difference between the normal and impaired GEJ. the normal value of which is less than 15 mm. The other index is distal contractile integral DCI, which helps determine the contractile strength of the peristalsis. The normal values range from 450 to 8000 mmHg second centimeter. Contractile deceleration point is another index which is about the inflection point in the contractile propagation, and distal latency, which helps to know about the integrity of the inhibitory pathway. Based on the HRM, there is a Chicago classification of the esophageal motility disorders. It divides the disorders into two, the disorders of GEJ outflow and the disorders of peristalsis. After the swallows are done, and a median IRP is calculated, which is the integrated relaxation pressure. If it is abnormal, that is if it is more than 15 mmHg and there are 100% absent peristalsis, we can go towards a diagnosis of achalasia. If it is not so, the initial swallow was done in a primary position and it is then again done in a secondary position. If the findings are still consistent with achalasia, we can still suspect and go ahead with the diagnosis of achalasia. If not, and there is 100% failed peristalsis, we move towards the disorders of peristalsis. If there is 100% failed peristalsis, it is about absent contractility in the esophagus. If there are more than 20% swallows with premature contraction, it is distal esophageal spasm, DES. If there is more than 20% swallows with hypercontractility, it is a condition of hypercontractile esophagus. And if it is more than 70% ineffective or more than 50% failed swallows, it results in ineffective esophageal motility. And thus the diagnosis of the esophageal disorders can be made effectively using HRM. The disorders at the level of upper esophagus are permanent trachopharyngeal relaxation. It is usually seen in neurologically impaired patients, which results in recurrent aspirations. Delayed or incomplete relaxation, it is seen in patients with Kyrie malformation. Cricopharyngeal achalasia is another condition which may be primary or secondary to neuromuscular disorders. The patients present with choking during feeding or respiratory distress during early infancy. The disorders at the level of esophageal body may be primary or secondary. The primary disorders are diffuse esophageal spasm, nutcracker esophagus, or hypercontractile esophagus. In this manometry graph, we can see a graph of nutcracker esophagus with long duration peristaltic waves. The secondary motility disorders include with disorders associated with reflux, which are Down syndrome, scleroderma, polymyositis, dermatomyositis, or lupus. The survivals of neonatal surgery for esophageal atresia also lead to a motility disorder in the esophageal body. The reason of which may be because of the malformation of muscle layers, abnormal extrinsic and intrinsic innervation, LES abnormality leading to GR, or constant swallowing problems which are associated. The other conditions associated with this motility of esophageal body are chronic intestinal pseudoobstruction, Hirschsprung disease, congenital central hypoventilation syndrome, Golden Hair syndrome or Noonan syndrome, survivals of CDX surgery, corrosive injuries of esophagus, and eosinophilic esophagitis. Coming to the disorders of distal esophagus, they may be a primary GR, which is because of the failure of GE barrier and abnormal motility, achalasia, which is because of the hypertonic lower esophageal sphincter, and secondary motility disorders again, which may again be the manifestations of systemic disease, which is Chagas disease, reflux-related dysmotility, scleroderma, or other rheumatological disorders. Coming to the diagnosis, a diagnosis of DES can be made on barium swallow by the visualization of simultaneous non-propulsive contractions. On barium swallow, it is seen as a corkscrew deformity, and as a secondary pathology, a high epiphanic diverticulum can also be seen. On HRM, the diagnosis of DES is made by the simultaneous non-peristaltic contractions which are seen. They are repetitive and multi-peak contractions. They are spontaneous in nature, and intermittent normal peristalsis may also be seen. These contractions which are present are of increased amplitude and increased duration. For the diagnosis of nutcracker or jackhammer esophagus, the mean peristaltic amplitude in an HRM is more than 180 mmHg. And there's an increased duration of contraction, as we can see in this graph also, of more than 7 seconds. The peristaltic sequence, however, is known. In cases of hypertensive lower esophageal sphincter, the LES pressure is elevated, but there is normal LES relaxation and normal peristalsis in the esophageal body. There are conditions where the motility of the esophagus can be reduced. In ineffective esophageal motility disorders, there decreased or absent amplitude of esophageal peristalsis that is less than 30 mmHg. and there are increased number of non-transmitted contractions. In these two graphs, initially we can see an absent contractility where no peristalsis is seen, and the DCI is 0 mmHg second centimeter. In ineffective esophageal swallow, when the DCI is less than 450, these swallows are known as ineffective, and when it is less than 100, it is known as failed peristalsis altogether. Coming to achalasia cardia, the incidence of which is 6 per 100,000 population per year. The LES is hypertonic in this condition and does not relax during deglutition. Dilated esophagus and primary hyperperistalsis results in the ineffective propulsive function. It is rare in young children and diagnosed in late childhood or early adolescence. It is essentially a pre-malignant condition and has a risk of 8% over 20 years since diagnosis. More commonly, squamous cell carcinoma than adenocarcinoma. The pathophysiology lies in the paucity of c-KIT positive interstitial cells of Gall, depletion of neuronal nitric oxide synthase, immunoreactivity in the esophagus. The NO synthase is responsible for the synthesis of NO, nitric oxide, which is the non-adrenergic, non-cholinergic neurotransmitter, which helps in the smooth muscle relaxation of the receptive relaxation. There is progressive degeneration of intrinsic innervation, which eventually may lead to the functional loss of myelin plexus ganglion cells. This essentially results in the loss of inhibitory signals, and because of which there is unopposed excitatory signals, which results in inability of the LES to relax. A suspected autoimmune process may also lead to the loss of myelin plexus, as in histopathology, many a times it is seen that the remaining ganglion cells are surrounded by lymphocytes and eosinophils. The achalasia is also associated with the dysfunction of the upper esophageal sphincter, which results in the difficulty with belching. Normally, the gas from the stomach triggers relaxation of the upper esophageal sphincter. But in this case, the loss, because of the loss of inhibitory neurons, the reflex is lost. And this also acts as a contributing factor to the esophageal distension seen in achalasia. This is a pictorial representation of the stimulation by normal population by acetylcholine in the upper esophagus, which results further in the relaxation of the lower esophagus. But in cases by nitric oxide and VIP neurotransmitters. But in patients of achalasia, this is not possible, and thus the relaxation is not there, and the pathology then ensues. Achalasia is associated with AAA or Algrove syndrome. It is an autosomal recessive condition caused by the AAAS gene mutation. It is associated with adrenocortical insufficiency and alacramia. There's a Aladdin syndrome, which is associated with achalasia, adrenal insufficiency, alacramia, and neurological disorders. Chagas disease may result because of the relaxed lower esophagus. It is essentially by an infection by the Trypanosoma cruzi, which results in the widespread myelin plexus destruction and further leading to achalasia. These symptoms of the achalasia are insidious in onset with gradual progression of the symptoms. The dysphagia progresses from solids to liquids with weight loss. These patients frequently undergo treatment, a conservative management for GERD before the diagnosis of achalasia is established. A triad of dysphagia, regurgitation, and weight loss is usually seen when a diagnosis of achalasia is made. Other symptoms which could be seen are heartburn or reflux, regurgitation, chest pain, epigastric pain, and odynophagia. Respiratory symptoms may also be present in children, which may be related to chronic microaspiration due to failed clearance of food and liquid. Sore throat, hoarseness, postnatal drip is seen in up to 70% cases, cough in up to 60%, which is nocturnal in nature. These symptoms of respiration are usually followed by symptoms of dysphagia, which has been present for more than 2 years. In younger age patients, chest pain and heartburn are usually associated. In obese patient where BMI is more than 30, the patients can also present with choking and vomiting. The patients of Algrove syndrome present with also symptoms of absence of tears, symptoms of progressive adrenocortical insufficiency, which is progressive pigmentation and asthenia. Neurological disease symptoms can be present. These symptoms usually appear after the symptoms of achalasia, which is dysphagia, regurgitation. The diagnosis of achalasia on barium swallow is made classically by the word-beak appearance, which is formed because of the megaesophagus, stagnant fluid, and marked peristalsis of the esophagus. On manometry, incomplete lower esophageal sphincter relaxation is seen. Less than 75% relaxation is seen, as evident in both these graphs. There is peristalsis in esophageal body and an elevated LES pressures more than 35 mmHg with failure of relaxation. HRM again, as seen in which results in which is described by the Chicago classification, is the gold standard for diagnosis, and it also divides the achalasia into three types. In type 1, there is elevated IRP, which is diagnostic in all the three cases, more than 15 mmHg. In type 1, there is failed peristalsis completely with DCI less than 100. The histology correlates with increased ganglionosis and neuronal loss. In type 2, there is pan-esophageal pressurization in more than 20% of the swallows. These patients are more likely to report weight loss. Again, the histology correlates similarly. In type 3, there are so with increased IRP, there are premature contractions in more than 20% of the swallows, but DCI is normal, which is more than 450. These patients are least likely to report weight loss, but they're more likely to report chest pain as the presenting symptoms. In this case, histology is seen as preserved ganglion cells. On a diagnosis of HRM, the type 1 shows 100% failed peristalsis, DCI is less than 100, and we can see no peristaltic wave seen on the HRM. In type 2, there is pan-esophageal pressurization in more than 20% of the swallows. In type 3, there are premature contractions with DCI more than 450 in more than 20% of the swallows. Considering the HRM and Chicago classification in pediatric population, the indications are that of esophageal dysfunction when it is not explained by anatomic or well-defined etiologies, presence of dysphagia or adenopagia, suspected diagnosis of achalasia or other primary motor disorders, presence of GER after the other pathologies are excluded, to locate the lower esophageal sphincter or prior to fundoplication. But the use of HRM is limited in pediatric population as there is no normative values for pediatric patient derived from a healthy population. The development and maturation of GI system needs consideration, and even with respect to technical aspects of the study, the age of the child and size of the catheter needs to be correlated. The amount of fluid needs to be adjusted according to age, and child's cooperation is essential, and sedation may be needed for the study. Coming to the management, will be discussed by Dr. Shrilakshmi. So to classify the esophageal motility disorders, either GG outflow or
the management changes as per the classification. Yes. Now we come to the discussion of the motility disorders of the esophagus. As we discussed earlier, some of the disorders which affect the upper esophagus includes a permanent relaxation of the cricopharynges, which are seen in the, associated with the neurological disorders. There can be delayed or incomplete relaxation or absence of the relaxation, which is also called as a cricopharyngeal achalasia. So the diagnostic modality for these patients includes barium study and manometry. In the barium study of the patients with a permanent relaxation of the cricopharynges, there will be simultaneous opacification of the respiratory tract as well as the digestive tract because of the aspiration. And in the patients with a delayed or absent relaxation, as in the case of cricopharyngeal achalasia, they will have dilated pharynx, upstream dilatation will be there with or without the passage of the contrast into the trachea. And the manometry, however, as discussed, it can be difficult to be performed in the infants, especially in the when we have to study the cricopharynges. Coming to the management, in the patients who have a permanent cricopharyngeal relaxation and upper esophageal achalasia, it is better to go for the gastrostomy as they have an increased risk of aspiration in these patients. And in the cases of achalasia, we can try for a balloon dilatation or extramucosal myotomy by cervical approach. It can be most effective. And if the reflux is present concomitantly, we have to opt for a concurrent fundoplication in these patients as they can develop GERD in the future. Coming to the cricopharyngeal myotomy, these are performed for the problems of the oropharyngeal phase of swallowing, which cannot be solved with the medications. And we go for the open myotomy by a cervical approach. Here we give an incision along the anterior border of the left sternocleidomastoid muscle, and the myotomy will be performed on the esophagus. The esophagus will be identified either with the help of the diverticulum, which is usually present in the patients with the motility disorder, or because of the presence of a stiff NG tube. And we have to extend the myotomy incision cephalically by dividing up to 1 to 2 centimeters of the inferior constrictor muscle of the pharynx, and caudally we have to divide the cricopharyngeal muscle and cervical esophagus for a length of at least 4 to 5 centimeters to achieve an adequate myotomy. Coming to the disorders of the esophageal body, esophageal body can have primary motor disorders of the esophagus, which includes the diffuse esophageal spasm or a nutcracker esophagus. In the diffuse esophageal spasm, there will be simultaneous non-propulsive contractions or excessive proportion of a long duration waves alternating with the normal ones. And in the nutcracker esophagus, they will be having the extremely powerful high amplitude waves, which can be peristaltic or retrograde. And usually these are unheard of in the children. And when they are present in the children, they usually present with apnea, bradycardia, or sometimes bizarre posturing will be there because of the pain. And they can be food impaction when there is absence of any stenosis or an anatomical cause for the obstruction. The diagnosis includes a 24-hour manometry with the 24-hour ambulatory recording. Coming to the treatment of the esophageal body disorders, pharmacological treatment have been employed, which includes a prokinetic or a calcium channel blockers like nifedipine can be employed. However, the efficacy is it is not well studied in the children. Sildenafil, which induce the nitric oxide synthesis, and it relates to the nitric oxide related relaxation of the esophageal body and the lower esophageal sphincters. It has been introduced in the adults, however, it is not used in the children till now. Another modality of treatment is the balloon dilatation or an extended esophageal body myotomy, however, which are occasionally used in the adults. Long esophageal myotomy, the benefit of the surgery is present in the patients with the high prevalence of simultaneous waveforms compromising the esophageal propulsion. The prevalence of effective waveform during the males drop below the 30% is an indication for the long esophageal myotomy. The principles of the surgery of the esophageal myotomy includes we have to extend the incision of the myotomy distally below the level of the lower esophageal sphincter. Along with that, we have to do the partial quantiplication, and the proximal extent of the myotomy has to be confirmed with the HRM before the surgery. This is a pictorial description of the long esophageal myotomy. Here, the approach, if you are doing by the open approach, it is usually from the left thoracic approach. And if it is by the thoracoscopic, we can approach from the right or the left side. And we have to expose the esophagus. And after that, an incision will be made on the phrenoesophageal junction, phrenoesophageal membrane to expose into the abdomen. And we retract the fundus of the stomach so that the extension of the myotomy can be extended below the level of the lower esophageal junction, and we expose the gastroesophageal junction. And in these two pictures, we can see the myotomy being performed, and this extension of the myotomy has to be done below the level of the gastroesophageal junction, at least for 1 centimeter. And this is the reconstruction of the cardia after the myotomy. Usually what the disorders of the motility of the esophagus are usually associated with the diverticulum. The diverticulum which is associated with the motility disorders are the pulsion diverticulum. These are associated with the esophageal motility disorders and usually happens when there are two segments of the hypertensive segment in the esophagus in between the normal segment. And the traction diverticulum is another type of the diverticulum which is usually seen in the inflammatory diseases like TB, when there are inflamed lymph nodes, which leads to the diverticulum of the esophagus. Epiphrenic diverticulum is a type of pulsion diverticulum, which is usually seen in the terminal 1/3 of the thoracic esophagus, and it is seen adjacent to the diaphragm. And they're usually associated with diffuse spasm, esophageal spasm, achalasia, or non-specific motor abnormalities in the body of the esophagus. Here we can see a diverticulectomy being performed. When these diverticulum are associated with the motility disorder, esophageal myotomy from the proximal extent of the diverticulum to the stomach has to be combined with the diverticulectomy has to be performed. And if this diverticulum is suspended from the to the prevertebral fascia of the thoracic vertebra, a myotomy is begun at the neck of the diverticulum, and it has to be extended below the level of the lower esophageal sphincter. And the excision of the diverticulum by dividing the neck has to be accompanied with the closure of the excision site. Along with that, the myotomy has to be performed on the opposite wall, starting at the level of the diverticulum and at the proximal extent, and it has to be extended till the lower esophageal sphincter. This is a pictorial demonstration of a diverticulectomy of an epiphrenic diverticulum. Here we can see that the diverticulectomy is performed and the neck is closed, and the myotomy is performed and it has to be extended below the level of the lower esophageal sphincter. Coming to the eosinophilic esophagitis, these are usually having the allergic origin, and the symptoms of they will present with the symptoms of reflux or a food impaction. The biopsy of the esophagus demonstrates a heavy infiltration of the mucosa by eosinophils. The management of the eosinophilic esophagitis includes oral corticosteroids like fluticasone or an inhaled corticosteroids that have also been studied in the patients with eosinophilic esophagitis. Sometimes eosinophil stabilizer like montelukast has been employed, and in the patients who are presenting with this multiple rings, as can be seen in this barium study as well as the endoscopy, these patients might require dilatation when there is severe dysphagia is present without any stenosis. The dilators which can be employed are Melanese dilator or a Sabry's dilator. However, at the time of the dilatation, adequate precautions has to be taken as the esophagus is very friable in these patients and there is a risk of perforation. Coming to the survivors of the neonatal surgeries for esophageal atresia or esophageal atresia, these patients usually will have higher chances of GER, which is up to 20 to 63%, and an anastomotic stricture, which is also up to 60%, 18 to 60%. And there can be abnormal dysmotility of the esophagus because of the abnormal innervation or because of the abnormal musculature. And they can also have esophagitis or eosinophilic esophagitis. Some of the causes for GER in the patients of survivors of esophageal atresia includes excessive tension at the site of the esophageal anastomosis, or because of an abnormal esophageal motility, or because of the slow gastric emptying or abnormal gastric myocardial myoenteric activity. The management of these patients includes medical management with the PPIs can be tried. However, there is no role for prokinetics in these patients because of the lack of efficacy. In the patients who are refractory for the medical management, surgical management with the fundoplication has to be considered. And if they're refractory for the surgical management as well, then the total gastric dissociation has to be considered. Coming to the disorders of the distal esophagus, the first study is the disorder is the primary gastroesophageal reflux. Here, there will be failure of the gastroesophageal barrier and there will be abnormal esophageal motility. So, the mechanism of GER includes prolonged non-deglutatory relaxation or a decreased proportion of the peristaltic contraction after deglutition or reflux, and there will be and the amplitude of the waves, particularly at the lower end of the organ. Management includes medical management can be tried with the prokinetics, and this reinforces the failing sphincter, lower esophageal sphincter, and hastens the gastric emptying, and it also improves the peristalsis. However, if the patients are refractory for the medical management, surgical management with the fundoplication has to be considered, and the detailed discussion of the GER will be done in the next class. Coming to the achalasia, the mechanism, as the symptomatology and diagnosis has been discussed already, and now coming to the management of the achalasia, the medical management can be considered in the patients with the calcium channel blockers such as nifedipine, or sometimes even the nitrates has been employed in the management of the adult patients with achalasia. These medications alleviate the spasm. However, it is the use of these drugs in the children is yet to be studied. Injection of the botulinum toxin endoscopically in the 4 quadrants of the esophagus has been tried. However, it is not successful in the children. And even if we do the botulinum toxin, it is not a permanent resolution. It is just for the to study the effect of the myotomy if it can be effective or not. Coming to the balloon dilatation of the lower esophageal sphincter, it is, however, same thing. It has been studied in the adults and it is yet to be studied in the children, and it is yet not useful in the children. So, however, some favorable results have been found in the children of more than 6 years of age. We can use a pneumatic dilatation or a balloon dilatation, and it has to be done under the fluoroscopic guidance, and it has to be inflated. And adequate relief has been found in up to 50 to 60% of the patients in whom the balloon dilatation has been employed. Coming to the surgical management, which is a Heller's myotomy. This is an extramucosal Heller's myotomy. It is considered as the best treatment for the patients with the achalasia. It is performed either by the thoracic approach or by the abdominal approach. Both of the approach has its own perks. However, usually when the myotomy is performed, it is seen that 50% of the patients will develop reflux in the follow-up, and hence the myotomy has to be combined with the fundoplication to avoid such reflux. And hence abdominal approach, which allows us to perform the fundoplication along with that to ensure a complete myotomy, is considered as the best approach. And in that, laparoscopic approach is considered as a gold standard. when compared to the open approach. And to be performed the Wheeler's myotomy adequately, there should be a fall in the the sphincter pressure to less than 10 millimeter of mercury, and it has to be performed in the early course of the disease to achieve a better result. Coming to the principles of the surgery, here we do the extramucosal myotomy in the distal part of the esophagus, and at least 4 to 6 centimeter of the distal esophagus, the myotomy has to be performed, and it has to be extended at least 1 centimeter below the level of the lower esophageal sphincter into the anterior wall of the stomach, and there should be a complete division of all the circular muscles and collar-sling muscle fibers. And the undermining of the muscularis has to be done to allow for the wide separation of the esophageal muscle, and it has to be covered by either short floppinism or an anterior door or a posterior topid fundoplication to avoid the reflux. Coming to the surgical procedure, in patients with the open myotomy, preoperative esophagoscopy is performed by some of the surgeons to evacuate the esophagus, and we have to place a medium caliber stiff NG tube in the esophagus. After that, the upper abdominal midline incision is given, extending from the xiphisternum till the umbilicus, and we expose the upper abdominal esophagus, and the fundus of the stomach has to be mobilized to ensure the appropriate fundoplication. And after that, the mobilization of the distal end of the esophagus has to be ensured circumferentially, and in the for at least up to 5 to 8 centimeter into the mediastinum. The myotomy has to be performed for a length of up to 4 to 5 centimeter, as we discussed earlier, in the distal esophagus, and it has to be extended into the anterior wall of the stomach. And after that, initially the superficial incision will be marked, and after that the muscle has to be separated completely from the underlying mucosa with the blunt dissection, and we have to ensure that at least more than 50% of the circumference of the esophagus is free, as is seen in this picture. After that, we have to narrow the hiatus, and fundoplication has to be done. Either in patients with the open myotomy, we can consider for the floppy nascent fundoplication, or a dot or a topid fundoplication can be done over the distal 1 to 1.5 centimeter of the esophagus, and the esophageal sutures are placed over one side of the divided esophageal muscle to avoid the reapproximation, as can be seen in this picture. Coming to the laparoscopic myotomy, this is considered as one of the best approach for the patients with the achalasia. Similar to the open myotomy, we can do the preoperative esophagoscopy to evacuate the esophagus, and the patient positioning and the positioning of the surgeon is as shown. The surgeon will be standing at the foot end of the patient, and the assistant surgeon will be standing on the left side, and the scrub nurse will be standing on the right side. Port placement, we can employ either a 4-port technique or a 5-port technique. In the 4-port technique, we will be placing an umbilical port, and one port will be put on each side in the right and left upper mid abdomen, and one below the level of the below the subcostal margin to the left of the falciform ligament. It is for the retraction of the liver. Additional port, it can be placed above the level of the umbilicus to the right of the falciform if the if the stomach needs to be retracted downwards. As we can see here, once the abdomen is entered, liver has to be retracted. For the liver retraction, we can either use a grasper which is holding onto the muscular diaphragm, or we can place a triangular liver retractor for the retraction of the liver. And after that, we divide the phrenoesophageal junction, and the dissection will be carried out on the anterior and the lateral wall of the esophagus. In the laparoscopic myotomy, we will not be doing the posterior dissection. It will be only in the anterior and the lateral dissection along the esophagus. And the anterior crust is lifted, and the dissection will be carried out in the mediastinum to free the esophagus. And we have to expose at least up to 5 centimeters of the esophagus in the mediastinum. And after that, the esophageal myotomy will be performed. And initially, the superficial incision will be marked at the site of the myotomy. And then using either a monopolar or diathermy or an ultrasonic scalpel, then the blunt dissection will be carried out to separate the longitudinal muzzle layer, and it will be separated for up to 5 centimeters into the mediastinum, and 1 centimeter below the level of the G junction, as adhering to the principles of the myotomy. This is a picture which is showing that initially the myotomy site will be marked, and we can see the longitudinal muscle fibers which are yet to be done dissected. And after that, the blunt dissection will be carried out to separate the muscle. And once the appropriate myotomy has been performed, we can appreciate there will be pouting of the underlying mucosa without any evidence of any leak. Some of the optional maneuver which can be employed post-surgery is one is the instilling the air into the esophagus and stomach where we can confirm the check for the leak, or it can do an intraoperative endoscopy to visualize the GE junction, and dynamic manometry or an endoflip balloon measurements can be employed to check for the adequacy of the myotomy. This will be done after the myotomy. Anterior door or a post door fundiplication is usually carried out, and gastric fundus will be fixed to the anterior esophageal muscle layer and with the non-absorbable sutures. Some of the complications of the myotomy includes bleeding from the myotomy site, usually which stops spontaneously, and there can be development of the tension pneumothorax during the when the dissection of the esophagus is being carried out in the mediastinum. There can be incomplete myotomy or a too tight of a fundoplication, which might necessitate a repeat myotomy or a balloon dilatation in the postoperative period. Sometimes there can be a delayed or a missed perforation when we are using the monopolar diathermy to carry out the myotomy, and they can present with the mediastinus or mediastinitis or a peritonitis, which might require appropriate management in the, if present. Post-operatively, after the myotomy, the patients will be usually relieved of the symptoms at once, and routine contrastivity is usually not routinely indicated. Esophagus remains dilated for several months and years after the myotomy. The function of the esophagus rarely returns to the normal. There can be residual or recurrent chest pain in 25% of the patients, and this is because of the diffuse esophageal spasm. And this can be controlled with the medications in most of the patients, but if the symptoms are refractory, then there can be need for the esophageal replacement. Coming to the assessment of the outcome, there will be symptomatic improvement after the myotomy. However, it is not reliable, and we can do a lower esophageal pressure or esophageal baseline pressure can be done. And however, the best method to assess the outcome of the myotomy is by the scintigraphy assessment of the esophageal emptying time. Coming to the poem, that is the per-oral endoscopic myotomy. This has been rapidly adopted in the adults and is being employed in the children as well in the recent time. And here we do the endoscopy and do the myotomy of the circular muscles endoscopically. The endoscopy will be performed initially, and the important measures will be taken, that is esophageal gastric junction will be identified, mucosotomy site will be identified, and the myotomy start and end points will be marked. And after that, the 5 ml methylene blue will be injected into the submucosal plane at the site of the mucosotomy site. So here we do a mucosotomy for a length of at least 2 centimeters using the special knife, that is either a triangle knife or a straight knife, which is available. And after that, the endoscope will be inserted in along with the dissecting cap, and it will be insinuated between the submucosa and the muscular layer. And it will create a tunnel in the submucosal layer, and it will be, this tunnel will be made past the lower esophageal junction. And the myotomy will be done, as we can see in this. This is a submucosal, this is a mucosotomy site, and this is a submucosal tunnel which we have created. And these are the circular muscles which are yet to be, which are yet to undergo the myotomy. And after that, the myotomy will be beginning, and we begin proximally in the esophagus, and it will be extending up to 2 to 3 centimeters into the stomach. As we can see here, in this images, we have done the myotomy, and it is we have to make sure that this is extending beyond this level of the stomach. And after that, the mucosotomy site will be sutured. This is a video. Unable to. As we can see here, before the poem, the diameter of the lower esophageal sphincter was 8.1, and after the poem, the diameter has increased to 12.7 mm. So as we see, as we saw that there are multiple modalities of treatment which can be useful in the achalasia, including the pneumatic dilatation or a poem or a laparoscopic Heller's myotomy or injection of the botulinum, and which has to be employed in which type of the achalasia is discussed now. So in the type 1 and type 2 achalasia, these patients will have the non-relaxing lower esophageal sphincter, and they will be having the absent peristaltic waves in the esophagus. So these patients will be benefited more from the graded pneumatic dilatation or with the poem, or mostly with the Heller's myotomy. In the patients with the type 3 achalasia, these patients will have more of the spasmodic contractions will be there in the esophagus, and they will benefit more from the poem. And in the patients with the achalasia with medium to large Hadal hernia, the surgery has to be employed in these patients, and Heller's myotomy with the fundoplication is the treatment of choice for these patients. Coming to summarize the class. So as we saw that the normal esophagus, the length of the esophagus ranges from 10 centimeter in the newborn to 35 to 40 centimeter in the adults, and it has a two muscular sphincter. One is the upper and the lower esophageal sphincter. And some of the tools which can be employed to evaluate the motor disorders in the esophagus includes the barium swallow, endoscopy, manometry, scintigraphy, and pH metry, and also high resolution manometry. This high resolution manometry is the gold standard to assess the esophageal motility disorders. However, it has its limitations to employ in the pediatric populations. The disorders of the upper esophagus includes a permanent cricophageal relaxation or a delayed or an incomplete relaxation of the cricopharyngeus or cricopharyngeal achalasia. And the management of these patients include the pharmacological management, or if they're not responding, we can employ dilatation or a myotomy, or in the patients with the increased risk of aspiration, gastrostomy has to be considered. And the disorders of the esophageal body includes diffuse esophageal spasm, nutcracker esophagus, hypercontractile esophagus, are secondary to some of the systemic disorders or secondary to surgery such as esophageal atresia and CDH. And the management of such patients includes prokinetics and calcium channel blockers. And sildenafil has been employed in the adult and yet to be studied in the children. We can do the dilatation or extended myotomy. The disorders of the lower esophageal sphincter includes lower esophagus includes the GERD and achalasia. And as we discussed achalasia in this chapter, the management of the achalasia can be medical management or botulinum toxin or dilatation, and myotomy with fundoplication and poem. Thank you.